Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and I'm very excited to have back for another episode Dr. Bayan Al-Share, who is a hematologist and oncologist at Monument Healthcare Cancer Institute. Welcome back, Doctor.
Thank you for having me again.
I'm so glad you liked it enough that you said, yeah, I'll go back and talk with him.
Sure.
It wasn't too bad. Now, I believe the last time we had you on was episode 66 here on Doc Talk, where we talked about the rise of immunotherapy, which was a pretty exciting subject, I think, to cover, and it gave a lot of people hope, I think. Has there been anything new since we last talked about that?
Yes, actually, there is something new every day with cancer,
Sure,
with cancer
Yeah,
management.
there we go.
And with immunotherapy, I was just at a big meeting for gastrointestinal cancers, the annual ASCO meeting, that it actually showed us more results that in the early stages of some cancers, like the stomach cancer, the esophagus cancer, that we can use it even before surgery in combination with chemotherapy. They presented studies recently, and it showed that there is benefit. So we will start using immunotherapy in the early stages. And as I mentioned in our previous podcast, is that we are always hoping that we can use it earlier and earlier, so we prevent the late disease or advanced disease
Sure.
to develop. So here we go. We have a new use of it before surgery, so we can get more outcomes, and we're looking for more data.
Well, and that has to be exciting for you, of course,
It is.
as a doctor, when you get this information that now you know we're going to be able to help people faster.
Yes.
That must play a big part of that. And that's kind of, well, it is kind of what we're going to lead in here today with this topic, which is going to be about colorectal, colon cancer, as a lot of people know it. And we mentioned just briefly before we got started, and it's how I wanted to begin this podcast, is there have been more and more stories that have been coming out that I think people have taken notice of, that younger and younger people are getting this particular type of cancer, which is surprising you doctors, correct?
Yes.
So let's just start with kind of an overview of what colon cancer is, okay?
Yeah.
And then let's get into why it's happening earlier.
Yeah. So colon cancer is actually a growth that starts in the colon from the colon cells themselves. And this is an abnormal growth. It shouldn't happen, but it starts because of some genetic changes due to multiple factors. Some of them are hereditary and due to something that patients got or people get from their families with increased risk of having some genetic changes, or what we call mutations, or an inherited or an acquired thing, which is something that's from the environment. We say it's multifactorial. So in general, colon cancer is something that wrong happens in the colon, and it shouldn't happen, but it develops over, we know that it's not all of a sudden a cancer. Most of the time, this starts with a precancerous lesion, and it's something that might be preventable. And over years, the cells become more and more abnormal until they reach the point they are cancer.
Is it a slow-moving cancer in general?
In general, yes. So it's not one of the fast-growing cancers. This is common when we see our patients, and they ask us, do you think how long I've had this cancer? And most of the time we tell them, and of course depends on the stage, but most of it we tell them it's been years since it developed. Few years, we usually think that it starts by precancerous thing, what we call adenomas, or some the abnormal growths or polyps that starts in the colon, and it starts making more and more changes over time to cause cancer. And that's why we say that if you screen early and you do your colonoscopies early, this is something that you can catch before it becomes cancer, because it's not going to happen in a year. It's not going to happen in a few months. That's why we don't repeat our screening every year. We don't repeat our screening every few months, because we know that it's going to take a while, but we want to catch it at some point before it becomes cancer.
Well, and I believe that the general perception is that it's the age of, is it 45 for men and women?
Yes.
Okay. And that's been lowered now, correct?
Yes.
Why is that?
So we have a lot of demographic factors to look at and determine what is the perfect or the best age to start screening. Age is one of the things that are important factors to determine when we screen patients. We know that from a lot of data from before that colon cancer is uncommon before age of 40. So between 40 and 50 in that decade, you have a significantly higher risk of colon cancer at this age, starts at this age, but it keeps going up with decades of age. So at 60, you're at higher risk than when you were 40, or and at 70, you're even at higher risk. So we think this is the more significant time that we want to catch colon cancer earlier. Now the guidelines said 45, and maybe further data is going to shift it even to younger ages.
Right.
And this is very important right now because the hot topic in colorectal cancer is now the incidence of cancer in young population. Now we are finding that there are diagnoses of colon cancer even younger than 40, which is it was very surprising. Now we're more used to seeing younger patients who have colon cancer, sometimes in advanced stages at earlier than age of 40. So it's still not in the guidelines that we want to screen earlier.
Right.
And definitely there are a lot of other factors that would affect their risk of having cancer at younger than 40. But in general, we say that it's uncommon if you don't have a family risk factor, other genetic problems, to have colon cancer younger than that age.
So that's yeah. Do you guys as doctors, when you saw this data come out and how surprising it was, how would you know, I guess, if you're, say, 25 years old and all of a sudden, you go in and your doctor says, well, we might have to check this out because you might have colon cancer, because you've been told, well, I don't have to screen till I'm 45, so I'm not even going to worry about it.
Yes.
So what do you do in that situation then?
Yeah. So there are symptoms, definitely. There are things that we call them red flags to any symptom that we have. Of course, anyone can have pain, abdominal pain at some point, and we, most of the time, as younger people, we just ignore it. We're like, I don't know what happened.
Right.
I had a bug or something. But in general, the red flags, if there is abdominal pain that's not explained by anything else, if you have any bleeding per rectum, which is fresh blood or dark blood, changing color of stool, this is never normal thing to have. So this should be alarming, that you have to tell your doctor if you are having a bleeding that, and again, if it's a bleeding that is also recurrent, something that you've seen, don't ignore it. Abdominal pain that is persistent. You've been having this pain for a week and two and a month, and it's not going anywhere. This is one thing to report. Any change with bowel habits in general. You know your baseline, we call it. You know your normal. And then if you feel that there is significant change in bowel habits, let's say alternating diarrhea and constipation, or always constipation, always diarrhea, there is something that has to be investigated there. If you have an unexplained anemia, a lot of people, they go to their primary care doctors for their annual visits. They are anemic and they don't know why. There is no explanation for that. Nutritional status is good and they did not bleed from a surgery. They did not go through any major event that would lead to their anemia. We have to suspect that there might be colon cancer. So we don't want to scare everyone. It's just like, okay, everyone has to be checked for this. And we have guidelines that says at certain age we want it, but we don't want people to ignore it. And don't miss your colonoscopy when you are 45.
Yeah, right, exactly.
And one more thing is that if you have a family history, and you are younger than 45, and you have one of these symptoms, it means that you have to be screened, even sometimes without having the symptoms. If the family history is for a genetic problem, disease, or a syndrome, we call it, that predisposed your family members to be to have colon cancer at early ages or at younger ages, have to be screened earlier. And depending on what syndrome it is or how old was your family member when they got the cancer, you have to be screened accordingly.
So it's interesting when people say family history of things. Like, so if my uncle had colon cancer, is that considered a family history, or does it have to be more like a brother and a father and an uncle, or what it's hard for me to ask the question, I guess, but what is like family history of it?
Yeah.
What does that mean in your world?
How immediate the family, the relative has to be. So yes, so this is, it's very important to know what is the extent, but most important is first degree family relatives. Like if you have a brother, if you have a father, mother, sister with this is a first degree, or a son or a daughter who had this diagnosis. This is a first degree relative. Of course, this carries the highest risk of you having the risk of cancer. But sometimes you have to look at also second degree and third degree relatives and see if there is a pattern of genetics that are coming down the family.
Right.
If the grandfather had colon cancer, and then one of the uncles or the dad had cancer, and then now the son or the daughter had cancer, this means that there is a pattern. Like sometimes it skips generations, we say.
Sure.
Like sometimes the grandfather had cancer, and now the daughter has cancer, and no one in between. This is still significant. And it depends on the age that they develop the cancer. With time, we know that more of non-familiar risk factors happen that causes the cancer development. Like if the grandfather had the cancer at age of 80 and no one else had cancer, and now someone is getting cancer at age of 50, might be not related.
Sure.
Not necessarily related, but you never know. It has to be, at least mention it to your doctors.
Okay. Now, are the lifestyles that we live playing into this too? We know we got to eat better. We know we got to exercise more. We have to quit smoking. But are our bad habits, is that trending maybe in younger people getting this colon cancer as well?
I think so.
Okay.
This is very big risk factor. So when we go back to the demographics of colon cancer, we know that there is variability in the region of the colon cancer among the world. There is variability among the age, among genders, and ethnicities. But when we go back to all these factors, so we say geographically, globally, we know that there are certain areas of the world, they have higher risk of colon cancer, or they have more diagnosis of colon cancer. This is a reflection of something else. It's not the region. It's not that you live in North America and someone who lives in Africa, you're exposed to different, the genetics are playing. That's all, either the genetics or just being in certain part of the world. It reflects something else. Environmental exposures is one important thing that might be different. Diet, because every area of the world has certain dietary habits.
Yes.
And in North America is one of the areas that has high diagnosis of colon cancer. And we know that colon cancer is associated and it's related to obesity, to metabolic syndrome, which is just some imbalance in our body because with high blood pressure, high blood sugar, having diabetes, having dyslipidemia, or some imbalance in your cholesterol level as well. All of this is because of our habit, because here we don't eat much healthy. The other thing
That's an understatement, sure.
And the other thing that is interesting actually is there is big difference in the incidence of colon cancer between males and females. And we're like, why? Is it hormones? Is it something else? Hormones is one of the theories, but again, if you go back to our habits, you find that males, they tend to be less attentive to their diets.
Sure.
They eat less healthy. First, they ignore their symptoms, of course.
Right.
They tend to say, oh, I'm all right,
Yes.
until it's late. So that's one thing. But the other thing is that their diet. They might eat more of the red meat, more of processed food, fast food. They eat more salt, more sugar, and those are all things that we think that those are culprits for development of the colon cancer. And they drink more heavy
Right.
alcohol, which
Yeah.
is one of the risk factors as well.
Okay. All right. Let's talk about then the treatments that are available. I'm assuming that advancements continue to be made all the time, right? So if somebody comes in and they have early stages of colon cancer, then what's your next step with a patient like this?
So it depends on few factors.
Okay.
When we look at a patient with colon cancer, I have to look at patient factors and disease factors. The patient factors is that how urgent it is to take care of the cancer. Is it right now? Is the patient going through a bleeding, obstruction, perforation, which is just opening, the cancer just opened up in his abdomen or about to happen? Those are emergencies that I have to deal with it regardless of my guidelines, is that I don't care what stage you are, we have to take you to surgery right now. So this is one example of patient factors that might change the way I manage. But in general, the cancer factors or the disease factors that I look at is that what is the stage? And early stage versus late stage is very important. And then what is the exact stage is also very important. We usually, for the early stage, we look at colon as colon and rectum. This is
Okay.
the same. It's the same organ, right?
Right.
So rectum is part of the colon, but it's the fixed part of the colon in at the end of the pelvic area, and it has a lot of structures around it. So treatment is slightly different in early stages. So if I see someone who has a colon cancer, which we say right side colon cancer, left side colon cancer.
Oh, so it can be on different sides even.
Yes.
Oh, okay.
So colon, let me go back and
Yes.
just explain a little bit. So colon, it's a long tube. It's a long organ in our body that is in your right side. It goes, we call it ascending colon. It just goes up all the right side of the abdomen.
Okay.
And then there is the transverse colon that goes across the abdomen. And then it goes down, which is the descending colon, just going down at the left side. And then it ends up with the sigmoid, which is just the transition to go to the rectum. So it's a very long tube. And for us, the cancer doctors, we deal with each segment or each part of it as different cancer.
So cancer can be in any part of your colon?
Yes.
Okay.
And they tend to have different biologies, actually. So right colon cancer is slightly different than the left colon cancer, and we might use different treatments for them. But in general, anywhere other than the rectum, if I have an early stage colon cancer, I'm going to go for surgery first, if this is feasible, except in very, very rare cases where we give treatment before, systemic treatment we call it, before we send the patient to surgery. And then after surgery, the question will be, is it a stage 1, stage 2, or stage 3? If it's a stage 1 or stage 2, except some cases in stage 2, that I'm going to just say, okay, you had your surgery, we're going to start your follow-up and surveillance, you're not going to need anything else. If you are at higher risk stage 2 or stage 3, then we're going to talk about the role of chemotherapy after that. In rectum, it's a little bit different. The one missing part of cancer treatments in general, I didn't mention in colon cancer, is radiation. We don't use it in colon, but we can use it in rectum. Because rectum is fixed, so we can do an X-ray exposure to it. We can
Right.
hit it with the radiation. Colon is a moving target. It's
boy.
literally something that is causing the peristalsis, and the movement of the colon is just always moving. So it doesn't stay still. So the radiation oncologist will tell you, I will never give radiation to colon cancer. It doesn't stay still. But in the rectum, definitely, even in the early stages of rectal cancer, we use the chemotherapy, we use the radiation, and we use surgery. The order of it is changing. It changed a lot. First, we were doing surgery, then doing chemotherapy plus minus radiation. And then the standard became what we call sandwich therapy. We were giving chemotherapy and radiation, sending patient to surgery, doing chemotherapy and radiation again. And now we are moving toward doing all of it before surgery to give the best surgical outcomes. So that's, in general, how we treat the early stages of the cancer. And then the later stages, we just put them together as colon cancer and rectal cancer. We usually treat almost with the same treatments, but as I mentioned earlier, that right side of the colon is slightly different than the left side. So I'm using chemotherapy anyway for advanced stage. And I'm going to explain why. When you have an early stage colon cancer, it's either in the colon itself, so in the wall of the colon, or it extended around it, maximum to the lymph nodes, which are the first filtering station from the colon. So when a cancer cell tries to escape, it's going to escape outside the colon wall, we would say, to the other organs, or it's going to go with the flow of the lymphatics to the lymph nodes. Lymph nodes are the filtering area that will catch things early. And if it did not stop there, it's going to go to the blood, because the lymphatic system, it just drains into the blood. If you have a cancer cell that reached the blood, it's going to go anywhere. It's wandering in your blood anywhere in the body. So we don't know. I tell my patients, it's floating. It's in your blood, and it's going to plant its seeds somewhere. We don't know where. It can go to your liver. It can go to your lung, because blood goes everywhere.
Right.
So if it's an advanced colon cancer, the treatment is going to be through a treatment that I'm giving it to the bloodstream, whether it's a pill or it's an IV treatment, like chemotherapy,
Right.
immunotherapy that we talked about earlier. It has some role in certain cases of colon cancer, and targeted therapy, or biological agents, we call them. And those are all systemic treatment, or something that goes to the bloodstream, because I wanna kill those cells that are just wandering around, and rather than focusing on one area.
Right.
When it's advanced, I don't care about the cell or the mass or the lesion that is sitting in the colon, if it's not causing local trouble. I want to focus on the big picture and focus on the whole body and give you the treatment through the IV or pills.
So what is a prognosis for colorectal cancer now? Does it keep improving every year if it's caught early enough? Do you guys feel relatively confident that if we catch it early enough, you're going to be fine?
Yes, for the most part. Definitely the earlier the better.
Yeah.
Prognosis of colon cancer, we usually give it by stage. Usually for any type of cancer, or in solid tumors in general, the way that we look at the patient's outcomes, and whether they would have the cancer come back, or whether they would recover and be cured of cancer, depends on their stage, largely. Stage 1 is when the cancer is still in the wall of the colon. It's very early. If we cut that part, most likely you're going to do well. We say by 5 years, and 5 years is a very important landmark in cancer in general, that would the patient, how many of those patients who had stage 1 cancer would live, you expect them to live for 5 years. And in stage 1, we would say very close to 90% of those people, they would live up to 5 years. And then in stage 2, we know that it's slightly lower. So depending on other risk factors, we say it's in the 70s, 80s. Stage 3, it drops even further to the 60s. And then in stage 4 is the big drop.
Right.
Stage 4, which is where I cannot tell my patient that my goal is to cure you. My goal would be to put your disease in remission. So here, the old data that we have, before we had all the improvement in our treatments, it was saying that 11 to 13% of patients, they would live up to 5 years. And then what's beyond that, it's hard to predict. It's depending on the patient, how they do with their treatments. But now we're seeing higher numbers. We're seeing 5-year survival going up with our treatments to 30%, which is great jump in oncology.
That is quite a jump, yeah.
Yes, yeah, definitely. But we usually say 5 years because the risk of colon cancer coming back in early disease is actually up to 5 years.
Okay.
The highest risk is in the first 2 years. So we tell our patients, if we pass 2 years after you have your surgery without having any cancer coming back, most likely we're good. So at least we're holding our breath for the first 2 years.
Yeah.
And then for the rest of 5 years, you're still going to be all under follow-up and surveillance program. And when we reach 5 years, I always tell my patients that, well, you can look forward for the day you fire me, because you're going to fire me at 5 years and I'll be happy about it. Because at 5 years, we think that if the cancer didn't come back, then we're most likely that's where we are safe.
Okay. Now, I guess in order to wrap this up, I think the one most important thing, especially when you hit that 45-year mark in your life, is schedule those colonoscopies. That has to be the biggest preventative measure that you can take, isn't it?
Yes,
Okay.
yes. We really encourage people, because we've seen patients who missed their colonoscopy at certain age. And even now I'm treating patients where the colonoscopy time was at 50 and they were supposed to do it at 50. They got busy with life and forgot about it for a few years, and then they had the cancer as advanced disease. So we don't want to reach the advanced disease.
Right.
We want to avoid it. My husband is a gastroenterologist,
Yes.
so he always tells the patient when we were together, or tell people in general, they're like, "What kind of doctor you are?" He's like, "I'm the kind of doctor that you want to see so you don't see my wife." So,
oh, that's great.
so I really don't want our path to cross in the clinic, but cancer happens and we will deal with it, but if we can try to avoid it, this is the best
exactly.
thing.
I can't recommend it enough. Just do it. It's everybody gets so worried about the stuff you have to drink and the whole day you can't eat, but it's a 24-hour period, and you could literally be saving your life. And honestly, a colonoscopy is one of the best naps you're going to get too. I tell everybody that I've had 2,
Right.
and I wake up. It's a great day the rest of the day, honestly.
Yes.
You sleep so well. Well, Dr. Bayan Al-Share, thank you very much for coming in and talking about this again. And you're invited back anytime you've got something else interesting that you want to discuss, okay?
Thank you. Pleasure to be with you. Thank you.
Thanks very much.